At what point in a patient's disease now are you going to be testing the patient? I mean, we talked about when we would give drug, but what about the testing?
Yeah. So again, I think testing is incredibly key in all of this, right? I mean, again, this drug only works, Lero and entrectinib only works in patients who have either NTRK fusion or ROS, right? And ALK-ROS. And so you need to test, and NTRK fusion is a complicated molecular alteration to identify. And I would say next-gen sequencing is really the gold standard here, because there's so many different partners, so many different 1, 2, 3, and all different multiple partners. You can't really do just FISH. IHC right now is still kind of in development, but you really need NGS sequencing. What's interesting is that NTRK 1, 2, and 3, particularly NTRK 3, is a very, any fusions are very long. There's long introns and so forth. So you really need what's called RNA-seq or RNA-based NGS
yes.
in order to capture some of that. For example, the Foundation Solid Tumor CDX, which many community oncologists send for, covers NTRK 1, 2, 3, only ETV6 NTRK 3, but they may be missing 30–40% of NTRK 3 patients, if not more.
And given how common those are, that's a significant number of the fusions, right?
And so, you know, I recommend ordering Foundation Heme, which is kind of confusing, right?
Yeah,
but that's an RNA-seq
yes.
panel that Foundation will actually allow for solid tumors to be screened for. And so that would be my recommendation. Or there are other vendors, such as I think Caris has an Archer fusion assay, which also covers all of the NTRK fusions at this point.
So are you going to be recommending that everybody who gets diagnosed with cancer then get this panel? Or at the time of progression, what would be the point that you would be wanting to get testing done?
You know, what I recommend or what is really, what is commercially feasible is a different question, right? I'm a big believer that there are definitely patients who will benefit from this drug, and it's really upon us to identify these patients, right? And understandably, there are a lot of logistical barriers. I don't think that all payers will pay for NGS testing. But I think definitely patients who have kind of metastatic cancer patients who've at least failed standard chemotherapy, if not, you know, certain, as I shared, certain subsets of patients, such as those who may not have alterations that we would typically target, such as in lung or other tumor types like in thyroid, which I'm going to ask you a series of questions on, right? And so I think those are patients that are clearly worth testing NTRK fusion.
The next generation sequencing is really the key component of managing these patients. NTRK is not an abnormality that we typically order as a one-off. It's part of a much larger panel. And it's a bit complicated. It's a very large intron. Not all panels will necessarily detect every member of the NTRK family. So it's important for individual clinicians to talk to their pathologists, to talk to molecular pathologists if they're on staff. And if the tissue is sent out to a commercial outfit, to talk to the vendor that's actually providing the assay and doing the screening, whether NTRK is properly covered, whether they have DNA or RNA-based assays. I feel it's crucial in any patient with advanced non-small cell that ideally the next generation sequencing be done early on in their diagnosis, preferably at the time of diagnosis. Certainly in any individual with adenocarcinoma, regardless of smoking history, in any never smoker, remote former smoker, regardless of histology. But I suspect we're on the brink of an era where we'll be testing anyone with non-small cell, regardless of histology, regardless of smoking history. And if an individual has gone through a number of treatments, say they had high PD-L1, they initially responded to pembrolizumab, or were on some clinical trial to which they responded, and then pembro stopped working, they went on to chemotherapy. That patient has not undergone next-generation sequencing. They need to. Either it should be done on the original tumor specimen, the original biopsy, or, if necessary, the patient should be rebiopsied. It opens the door to a number of different potential actionable molecular abnormalities, not just NTRK, but other, in some cases, equally obscure mutations and rearrangements, for which there are now an emerging field of targeted agents that work specifically on oncogenic drivers. And in some cases, patients who had been told that they had only months to live because we were running out of treatment have enjoyed sustained survival because of that diagnostic intervention.
I'd wonder what your thoughts are then about any patient who's going to get systemic therapy, because of course in the metastatic setting I can see obviously you're going to want to give Laro if it's available versus, or RET inhibitors or whatever else you might find. But and on the other end of that spectrum, on a patient who's going to be cured because they have a stage 1 breast cancer, I can't imagine running a panel like this if they're going to be cured. But what about patients who might be looking at their primary surgery, a little bit more difficult surgery, and you're thinking, could a systemic agent help, or at first progression or earlier on in the stages than we would normally think? When would you be testing? Because even if it won't affect them immediately, wouldn't you want to know, or is there a place that you would say no?
I mean, I think going back to that question about the neoadjuvant setting, I think there are certain diseases that it may be worth exploring that, but right now I think it's too early for us to kind of just, make that call. I mean, the indication specifically is for patients who kind of have metastatic NTRK fusion histology. So
it'll be interesting to see the algorithms that will be generated in the next few months to years, because I think it's really going to be interesting to see where this might start having impact beyond what we would normally think. And we talked a little bit about which NGS tests that you would order, and we pointed out that the CDX Foundation 1 is missing many, so asking if you're going to send it to Foundation 1 to ask for the heme panel. But it seems like they're just growing. My list that used to be on one table is now 2 or 3 pages long at this time.
I mean, you're right. There are now many different vendors out there that are ordering these things, and I think the important point is you need to know what you're ordering, right? You can't just assume that it's going to have NTRK fusion or all the partners, et cetera. So I think it's important just to ask whether your rep who's involved, if you're need that information, or the website exactly know what you're ordering and what tests are being ordered on that. Right now, my understanding is that, and I'm not a molecular pathologist, but most community hospitals don't have their own NGS testing in-house in a community hospital. That much of this is too complicated, the bioinformatics, and so many of these patients' samples are being sent to Foundation and Caris and other places. But again, I think the most important thing is to know, what are you ordering and what are you testing for, right?
Which is so important, because it might say TRK, but it doesn't tell you anything about the granularity that you need to know.
Correct.